Mm.
Hello everyone, myself Dr. Shivani. I have completed my MS ENT and now practicing in the Mumbai. Today I want to explain about the anatomy of middle ear and mechanism of hearing and theories of hearing.
Yeah.
Middle ear cleft versus middle ear cavity. See, this is a area. This is a diagram which shows the what are the different parts of middle ear cleft. That is, first is the Eustachian tube, second is attic area, and third is the middle ear proper, then additus, antrum, and mastoid ear cell. This complete picture forms the area of middle ear cleft. And middle ear cavity, it is a small cavity that is the middle ear, which is shown in the middle of the this diagram. This is the difference between middle ear cleft and the middle ear cavity.
Right. So this photo is very important. You should uh, you should practice drawing this diagram because you can draw this diagram at many places in many questions.
Okay. Anatomy of middle ear. In this topic, we're going to see first is the middle ear cavity, what are the contents of middle ear, and what are the various compartments of middle ear. See, this is a six-sided box which is showing a proper middle ear cavity. Here we have also you whenever you learn about the middle ear cavity, you always compare it with a six-sided cuboidal box, okay, which consists of the roof, that is tegmen, which consists of the floor, which is a jugular wall, which consists of the anterior wall. In front of anterior wall, there is a carotid, hence it is also called as a carotid wall, and the posterior wall, which consists of the mastoid, hence it is also called as a mastoid wall, and the medial wall and the lateral wall. Okay, the medial wall is also called as a cochlear wall because it consists of the basal terms of the cochlea, and the lateral wall, which forms the tympanic membrane proper. So, firstly, we will see the lateral wall. The lateral wall, which is formed by the tympanic membrane. The tympanic membrane, here we can see the diagram, how this tympanic membrane is formed. The tympanic membrane, it is a bony tympanic ring and outer which consists of the proper pars tensa part and the pars flaccida parts, which form the lateral part of the tympanic membrane. The outer atic wall, it is a part of a squamous bone. It is a wedge-shaped plate of bone separating atic. This is the upper part, which is a pars flaccida part, which consists of the atic area. From zygomatic mastoid air cells laterally, scutum is a thin, sharp bone spur at the junction of the outer atic wall and the superior wall of the ESC give attachment to the pars flaccida. We should take into consideration that this pars flaccida form the outer atic wall, and this is a very important part because the most of the cholesteatoma and the first site where the cholesteatoma form is the Prusak space, which is present just behind this area, just behind this wall, and the Prusak space, the lateral wall of the Prusak space is formed by the atic area or the atic wall. Tympanic membrane. The tympanic membrane, it is a C-shape. Inner aspect has a gutter that is 1 mm depth and tympanic sulcus annulus. This tympanic membrane, it is fixed inside the tympanic inside the annulus, and this form the thick osteocartilaginous ring in the sulcus inserted in the annulus ligament. Tympanic spines and the tympanic canaliculi. These are the two other terms, that is tympanic spines is the anterior tympanic spine, that is the anterior limit, and the posterior tympanic spine, which is a posterior limit. And what is the tympanic canaliculi? It is a retrotympanic fissure, and it is consists of the chordae posterior and the chordae anterior.
So this you can see in the this photograph also.
Okay, these diagrams here we can see how properly they have shown every piece, every part of a tympanic membrane, which is very important for the PGs. Even from the first year, when we used to draw a diagram of a tympanic membrane, and we used to draw a CP, so that is central perforation. It is very much important to know the site first, which side the tympanic membrane is, and how we used to draw it. So see how it has been drawn, and which are the parts you see on the tympanic membrane, and which are the parts you see through the tympanic membrane. That is first the tympanic annulus at the level of the two spine, that is anterior and the centrally towards the lateral process of the malleus. See that in the diagram we can clearly see the long process, that is handle of malleus, that is long process, okay, which is in the pars tensa part, and the tympanic annulus, and there is a cone of light. That cone of light, it is seen in the anterior-inferior quadrant, which is very important. This shows that the tympanic membrane, it is in a usual site, that is, it is a normal site. Also, the umbo, which is a most lateral part of the tympanic membrane, that is the handle of malleus का जो सबसे last part होता है, that forms the umbo, and there is a round window, there is just a reflection of the round window which is seen through the tympanic membrane, that is through the transparent tympanic membrane. Okay, and there is a incudostapedial joint. We can able to appreciate it clearly if there is a normal tympanic membrane, and it is seen through, that is transparently through the tympanic membrane. Okay.
So you can see these things. Just see what I am saying. Uh, the one is parts. One is past this placida. Then two is short process of malleus. So just recognize this. Then C3.
Short process of incus.
Sorry, two. This is short process of.
Incus.
Yeah. Three is handle of malleus. This three. Four is umbo. Five is supratubal. Fifth shivari is five. This is supratubal recess. So you can. Six is tubal orifice. You stretch and tube. Then seven is hypotympanic air cell. Eight is stapedial tendon. Just see this. Eight is stapedial tendon. Then cauda tympani is labeled by C. This. Then I is incus. This. P is promontory. This is promontory. Na? O is oval window. Oval window. R is round window. This is round window. Oval round. Then this is T is tensor tympani. T is tensor tympani. A is annulus. So just see, this is very important for beginners to identify. Every time you do otoscopy, just try to recognize these muscle structures. These are the very important structures.
Okay. Now we'll see the inferior wall. It is fusion between the petrous and the tympanic plates, at the junction of which lies the tympanic canaliculi and jugular bulb posteriorly and internal carotid artery anteriorly. This diagram is very important. In this diagram, first diagram 2.10, here we can see how the opening has been seen, that is eustachian tube opening. There is a promontory area, there is a round window, there is a jugular bulb. This jugular bulb forms the floor of the floor of the medullary cleft. Okay, and in the second diagram also we can able to appreciate how there the tympanic membrane and the posterior semicircular canal, lateral semicircular canal has been clearly seen, and in laterally there is a presence of the JB, that is jugular bulb, which is present in the floor of the medullary cleft. Okay, and in the radiograph also we can able to appreciate where is the this that arrow is shown in the area of a jugular bulb. So it is very important to see the dehiscence of the jugular bulb. Many of the times, many of the patients, that is in the ENT, cholesteatoma, that is unsafe CSOM, is very much common and very much important. And in this particular situations, we used to see how these plates, this middle ear is covered by all the six bony coverings. If not, then there is a chances of spread of the infection towards these bony separations into the structures. Like if there is any erosion in the floor of the middle ear, it can lead to spread of the infection from the middle ear into the jugular bulb. So take a note of this. And you should also know that it is a site of a retrofacial approach. So it is very important that whenever we go for the approaches, there is a different meaning for the approaches, and there is how you have to take the approach. So the retrofacial approach is taken from this area. Okay.
This jugular bulb lies on the jugular fossa, which lies to medial to the mastoid segment of this seventh visual, and the inferior to the labyrinth.
Yeah. Okay. Now we'll see the posterior wall. As I have already told you that the posterior wall is also called as a mastoid wall. It is about 14 and it is formed by the petrous bone. It is also important. Anyone can ask you in the viva that posterior wall is formed by which bone. So you should be knowing this. Also, see the diagram how it has clearly shown that additus ad antrum, incudal fossa, and incudal buttress. These three parts are formed in the posterior wall of the middle ear, and this posterior wall is formed by the upper one-third, that is the posterior limit of the epitympanum, and the lower two-third is the posterior limit of the retrotympanum. It is also very important because this additus ad antrum also play important role in the spread of infection from the urticaria into the mastoid ear cell system through this additus ad antrum area. Okay. So and the lower two-third of the posterior wall, it consists of the three eminences, four spaces, and five ridges. The eminences are the pyramidal eminence, caudal, and the styloid. Four spaces are the facial sinus, lateral tympanic sinus, sinus tympani, and the posterior tympanic sinus. And the five ridges are the pyramidal ridge, styloid ridge, caudal ridge, ponticulus, and the subiculum. Okay.
This diagram is very important. You can draw this flow diagram in the DNB papers especially, and also in your MS, so you will get an
Yeah.
extra edge.
Yes. So the posterior wall. This is a very beautiful diagram in which we can clearly appreciate that how it has been drawn. See the seventh nerve, how the seventh nerve is beautifully drawn, and how this styloid process, subiculum, ponticulum, and the various structures are seen. You have to draw this diagram. It is very, very, very important. This is a schematic diagram of the retrotympanum. It is viewed by the mesotympanum. Okay, there are the three parts you must be knowing, that is epitympanum, meso, and hypotympanum. So firstly, whenever you are drawing this, take a note that seventh nerve is very much important in the ENT. Okay. This posterior wall, upper side, it is formed by the upper one, that is additus ad antrum. Okay. Then the facial sinus area, the caudal ridge, styloid ridge, ponticulus, and subiculum, this totally form the sinus tympanic area. And these are the two very important questions for the PGs. That is facial, that is sinus tympani, and the facial recess. These are the very important questions. You should be knowing what are the boundaries, what are the contents, and how to draw these areas. Okay. So take a note of this. And in the second, in the clinical picture, you can see how this area is seen. That is a styloid process, how this has been, seventh nerve is seen over here. Also, lateral tympanic sinus. Okay. The endoscopic view of the middle ear showing a different sinuses and the recesses of the retrotympanum, that is posterior tympanic sinus, sinus tympani, lateral tympanic sinus, facial sinus, and all the structures can be clearly appreciated in this area. But here you have to pay attention towards the sinus tympani area first and the facial recess area second. Okay. Similarly, in the radiograph also, we can clearly appreciate the sinus tympani area, which is between the ponticulus and the subiculum. Okay.
So they asked about the boundaries of
Boundary.
facial recess. So
Yeah.
medially,
So
laterally,
I
you should remember, and the superiorly. Superiorly, we have this fossa
thought
inculates.
process of
Yeah,
yeah.
fossa inculates, and then we have laterally this chorda tympani, medially vertical segment of the facial nerve. So at least this much you should know.
Okay. Now we are going towards the superior wall. The superior wall is also called as the tegment. The tegment tuberei over the eustachian tube. That is tegment over the epitympana. Okay. The tegment anterior over the attic. In the anterior part, it is completely formed by the petrous, and in the posterior part, it is formed by the squamous bone. Okay. Between the tegment plate and the anterior limit of horizontal plate, the cog. Cog, it is a very important area. It is a 0.5 mm long, 1 to 2 mm anterior to the malleus head, heads to the cochleariformis process. This is very important because this cog area, it is a bony extension from the upper part, that is from the petrous part of the temporal bone, and it is dividing the upper epitympanum into anterior and the posterior part. So it is very very important to know, and it is also a very common viva question, and what is the cog and what is its importance. So please take a note of this. See, in this diagram, how this is beautiful a diagram. Here we can able to appreciate how the extra auditory canal is differentiated. It is separated from the brain by the thin bony plate, that is tegment, and this bony thin plate tegment is giving us some part showing a elevation, and this elevation is formed by the superior semicircular canal. You can able to see it in the first diagram, that is 2.22. Okay, the image of the tegment in the coronal plane. The tegment slopes down above the antrum and then goes to cover the superior semicircular canal. This semicircular canal also, there is a clinical point there, that if there is any dehiscence of the superior semicircular canal, it is also called as a third window phenomena. There is a first window, there is a second window, and there is a third window phenomena is there. And this third window phenomena is because of the superior semicircular dehiscence. So this is also one viva question which is commonly asked in a PG exam. Okay,
And this
and
is
see the second diagram. See the second diagram in which it is a coronal plane showing the relationship between the tegment and the bony external auditory canal. Notice the tegment rises up as we move medially. Okay. See how medially this has been raised up. Okay.
so
And
so
here external auditory
this is
canal.
a wonderful surgical significant that tegment is not uniform. No,
Yeah.
it is rising up. So you have to keep this in mind while drilling. If you are a beginner and you are drilling for the cortical mastectomy, then you should keep this in mind. And moreover, this superior semicircular canal dehiscence is a very important question. It is a 20 marker question in the PG exam. Yes, you can continue. No?
Okay. Please go ahead. Yeah. Next, here also in the diagram, it is a superior view of the tegment from the middle cranial fossa, demonstrating the setup of the temporal bone. Okay. Here also you can able to appreciate how there is a petrous bone, tegment plate, petrosquamous suture, horizontal plate. This is a very, actually in a normal bone, these are very minute structure. So you should be knowing each and every point, so that whenever you are going to drill that bone, you must be knowing each and every small part, so it will help you to be precise in your surgery. Okay. Now moving towards the anterior wall. The anterior wall has three parts, that is lower, middle, and upper part. In the lower part, there is it is also called as the anterior wall of hypotympanum, because in the lower part there is a hypotympanum area, tympanic area. In the middle part, there is a protympanum, tensor tympani muscle, and eustachian tube. This we have seen on in our UG book, that there is only a two opening which we used to learn every time, that there is a tensor tympani muscle opening and eustachian tube opening. And this area which is covered by these two openings is called as a protympanum. And in the upper part, there is a root of zygoma and anterior wall of epitympanum. Here, very important structure which lies in this anterior to this anterior wall. It is a carotid artery which enters the anterior wall and enters the temporal carotid foramen, ascends vertically in the anterior wall of the hypotension and in the medial wall of the bony eustachian tube, and at the area just beneath the cochlea, it turns anteromedially at 90 towards the petrous. Okay, this is an important relation you should be knowing, and that is how this carotid artery is entering into the external means in the middle ear. Okay. Yeah, this is a diagram. See the anterior wall of the middle ear. anterior wall of the right middle ear, that is upper third, middle one third, and the lower one third. See, and notice the internal carotid artery. Okay, this atic area, seventh nerve. Okay, tensor tympani muscle. Yeah, you can see, appreciate the eustachian tube opening and the round window opening. Okay, and see how promontory is also, that promontory is an elevated area which is also we can able to appreciate in this diagram. Yeah. Now moving towards the medial wall, this medial wall separate the middle ear cleft from the inner ear. As we know, as we are going from outer part, outer there is external ear, middle ear, and the inner ear. So medial to middle ear is the inner ear, and the tensor tympani muscle anteriorly and the facial nerve posteriorly divide the medial wall into the upper one third and the lower two third. The upper one third is epitympanum bounded posteriorly by the lateral semicircular canal, and lower two third part. Okay, see how there is a promontory. There is an oval window area, there is a round window area, and there is a ponticulus and the subiculum, what we have seen in the posterior part. Okay, you must be remembering that. Yeah. Now medial wall. The cochlear processus cochleariformis is a slightly protruded curved bone, triangular posterior limit of the tensor tympanic bony canal, and this tensor tympanic muscle curves medially to attach to the malleus at this point. You will see a proper diagram where there is a how this tensor tympani is coming from the opening along with the eustachian tube, and how it is curving and going medially towards the and attaches to the malleus at this point. Okay, and one important point is also there, that is facial nerves which runs obliquely above the promontory and above the oval window and below and medial to the lateral semicircular canal, and it then takes a turn to become the mastoid segment. So what is the second genu will we can able to appreciate the second genu, that is the second part, that is the second turn of the facial nerve. This can be seen in the medial wall of the middle ear. Okay, in the diagram we will see. Yeah, this is anterior antrum, mesotympanum, and the protympanum. Okay, this is the diagram which is very important. That is tegment plate of the petrous bone, petrosquamous suture, and horizontal plate of the petrous bone. This is very, actually it is a very gross diagram. It is if you can able to draw it, please draw it, because this is very important in terms of which can fetch you extra marks in the PG exam. Okay. This is the endoscopic view of the right ear, showing the different sinuses and the recesses of the retrotympanum. We have already, means I have explained that in retrotympanum, you have to be thorough with the facial recess area and the sinus tympanic area. Here we can clearly appreciate the seventh nerve in the superiorly, most superiorly the seventh nerve, then the facial sinus area, lateral tympanic sinus. Okay, then the sinus tympani area, above is the ponticulum, below is the subiculum, then the oval window area, round window area, and the promontory. This is a very clear diagram, and same as this we can able to appreciate in the normal person also. So it is a very important diagram, very important endoscopic view. Okay, now moving towards the contents of the middle ear, there are the ossicles, joints, muscles, nerves, and the arteries. Okay, the ossicles are the malleus incus and stapes, which you all know, and there are the two joints, that is incudomalleal joint and incudostapedial joint. Incudostapedial joint, it is a saddle variety of synovial joint. Okay, these two, incudomalleal and incudostapedial joint, both are the saddle variety of joints. Okay, and there are two muscles which are very important, that is tensor tympanic muscle and the stapedius muscle. There is wrongly there is the written over there, that is stapes. There are two muscles, that is stapedius muscle. Okay, which is the smallest skeletal muscle, and it is supplied by the seventh nerve. Then the nerve is the facial nerve, tympanic plexus, and the lateral superior petrosal nerve. Okay. Then there are the arteries, that is anterior tympanic, posterior auricular, inferior tympanic, carotid artery, caroticotympanic, and the middle meningeal artery branches. Okay. See, and here it is a diagram of the first ossicle, that is malleus. Malleus is mostly 8 mm in diameter, and it is 8 to 8 mm in diameter, and see there are the two processes, that is anterior process and the lateral process, which you can appreciate in the red color in this. And it has a three. This bone has a three parts, that is malleus, neck, body, and the handle. There are four parts actually. Okay, and there are the facet for the incus in this area, which is you can appreciate in the blue color, and the body of the this body and the handle forms an angle of 140 degree. You can clearly appreciate in this diagram. Okay, and there are the various attachment. How see in this second diagram, you can see how the malleus is attached to the various structures of the middle ear. Okay, this is a schematic diagram shows various malleal ligaments and tensor tympani suspensory ligaments. That is anterior malleolar ligament. See, anteriorly there is anterior malleolar ligament, which you can appreciate in the blue color. Then the posterior malleolar ligament. Okay, there is a superior suspensory ligament and the posterior malleolar ligament. The anterior and the posterior malleolar ligaments and anterior suspensory ligament, these all are seen how they are specifically attaches, and these are attaching the malleus to the other parts of the middle ear. Okay. Next is the incus. There are the three parts. The incus is the largest. Okay, incus is the largest ossicle among the three. This you have to take a note. And this is clearly given in the shampoo. That is, incus is a long means the biggest among the all three bones. Okay, and there are the three parts, that is a body, short process, and the long process, and there is a fourth ossicle present, which is called as a fourth ossicle. Actually, it is a lenticular process of the incus. It is called as a fourth ossicle. Okay, this you have to remember because this is a very important question in the PG Viva exam. Okay, and this short process of incus together, this short process of incus, we called it as a fossa incudis because it is a occupying the small area there. And in this diagram also we can able to appreciate how this incus is attached to the various other ligaments. That is a superior incudal ligament and the posterior incudal ligament. Okay, and you can also able to appreciate the facet for the malleus. Okay. Okay. The third ossicle is the stapes. The stapes, it consists of the head, footplate of the stapes and the anterior crus and the posterior crus. Okay. And here in the footplate of the stapes, you have to specifically remember what is the diameter. That is 3 mm diameter. The 3 into 1.5 mm is the dimension of the footplate of the stapes. This is also one of the important Viva question. Next, the anterior and the posterior crust, and the how these parts are attached to the various parts of the other part, that is sacral and the uteral. Okay, and the second important attachment of this is the tendon, that is a stapedial tendon, which is very important in the stapes surgery. And you normally the PGs who come across this area, whenever you are doing a stapedidotomy or stapedectomy, this is a very important part you must remember about the stapes. Okay, the stapedial tendon and the pyramid.
This is very important. See here, the distance are marked 1 mm and 1.5 mm. So
Yeah.
whenever these perforations are made, they are not made in anterior part. Either they are made in middle or
Middle
posterior
part or
part,
posterior part.
preferably in posterior. But some few people also do in middle part, which is ergonomically and which is easy to do actually. But ideally, that should be done in posterior part.
Okay, and this is also very proper diagram in which we can see a superior view of the right middle ear, that is showing the superior incudal fold. You can able to appreciate that is superior incudal fold, medial incudal fold, and the lateral incudomalleal fold, and the posterior incudal fold, tensor tympani muscle, stapedial tendon, anterior malleolar ligament, lateral malleolar ligament, cochleoformis process, seventh nerve. Okay, this is also very important diagram. You should know this. Okay, and in the initial stages, actually, you try to appreciate from where the diagram is drawn. It is drawn from the upside down, and it is here you can only appreciate the malleus in the upper part and the incus, that is a some part of the body, and the short process of incus is there. So first try to appreciate that and then try to appreciate how in upside down we can able to appreciate this part and the various attachments of the which are various ligaments which are attached to the malleus and the incus. Okay. Yeah. Here also in the second diagram, that this is also superior view of the right middle ear, showing the middle ear ossicles. Okay, ligament and the mucosal folds. That is anterior malleolar ligament, lateral malleolar ligament, posterior incudal ligament, tensor tympani muscle, cochlear formis process, pyramidal eminences, lateral semicircular canal, tensor tympani fold, anterior malleolar ligament fold, and lateral malleolar fold, superior malleolar fold, middle incudal folds, and the lateral incudomalleolar fold, superior incudal fold, and the posterior incudal folds. These all actually this is very seems like it is very difficult, but it is very important whenever you are doing any surgery, that is cholesteatoma for unsafe CSM and cholesteatoma. It is very important to know all such attachments, because these are the various pathways through which the cholesteatoma spreads.
So today we will cover till here only. One more thing, I would like to stress upon that key how initially if we see these photos it becomes very difficult key how we can remember, but it the number of times you see, for example, you have seen in surgery you try to appreciate these things, these folds and all, and if you are having problem, if you are assisting the surgeon, ask them to show. uh, it is also important. Likewise, your life will be made easier by your senior, by your faculty, if they are interested to passionately show you by using endoscope or by using microscope. Many times they use endoscope to show us these different type of folds. So the seniors, the good seniors, I'll request the seniors to take pain in teaching your juniors. That will actually, this will become a tradition and it will go down the line, and consequently the more trained juniors you have, your headache will also be less, and consequently the more skilled, the more talented juniors you have, the even in private practice, the good cases you will expect good cases, good the landmark cases which you can publish, and that will give credit to your name also. If you have good juniors in your area, whom you have trained, then only you can expect such good cases to be diagnosed at the first place and then managed. So we'll cover the part 2 in another set of lecture. Hope you enjoyed this.
Yeah.
Bye bye.
Okay. Thank you so much.